So as you know, our ideas forums are set up to present ongoing work and sort of interesting ideas in the Alzheimer's disease and sort of dementia space. I'm Kyle Walsh. I'm the Duke lead for our research education component, our Alzheimer's Center. Jan Busby Whitehead is our UNC lead, and I believe she's on or will be logging on shortly. Today, we have an earlier time because our guests are in a different time zone. We're so excited that they were able to join us and take time out of their busy schedules to talk to us about dementia care in Zambia. So I'm going to go ahead and just briefly introduce Dr. Deanna Saylor, who I've known for actually many, many years since we were undergraduates together. So Dr. Saylor is a neuroinfectious disease and neuroimmunology specialist. She's also a trained neurologist and has a strong interest in neurological complications of HIV infection. She has a particular interest and has spent many years devoted to global health and neurology research in the global health context, specifically focusing on better understanding neurologic disease burden in resource-limited settings, as well as improving neurology education. And she runs a neurology residency program in Zambia. And I believe it's perhaps the only one in a fairly sizable distance. And so today we're going to hear from some Zambian neurologists about dementia care. And, I think that there are potentially a number of things we can learn and think about as we consider, the sort of relationship between dementia in sub-Saharan Africa and dementia in the United States. And certainly, one thing that is of particular interest to me, and I know many of you on the line, is this idea of infectious etiologies and infectious origins in dementia, and what we might be able to learn about US-based dementia from what can be learned and what this group is doing in Zambia. So with that, I will turn it over to Deanna, and she can introduce our first speakers.
Thanks so much, Kyle, and thanks to everybody for attending today. It is my privilege to introduce the next three speakers who are really the main event here. So we'll get started. Our first speaker is going to be Dr. Moses Mata. Dr. Mata was one of the graduates in our second class of neurologists in Zambia. He has a special interest in neuropalliative care, and he actually is coming to you from a different time zone as well, because he recently relocated to San Francisco, where he's completing a Global Brain Health Institute fellowship through the University of California, San Francisco, and further developing his interest in cognitive neurology and dementia research. And so he's going to give us our first talk today, focusing on the epidemiology of dementia in sub-Saharan Africa. So Dr. Mata, I'll turn it over to you.
Thank you very much, Deanna, and thank you, everyone. I hope you can hear me okay.
Yes, I can hear you.
Sure. Let me just go ahead and share my screen. Please let me know if you can see my screen all right.
Yep, we can see it, and in presenter mode. Very good.
Great. So as mentioned, that is me. And maybe over the next 5-6 minutes, I will just introduce the rest of the talks and say a little bit about what we think we know about dementia in Zambia, a little bit about the southern part of Africa, why we don't know more, and what the little that we know is pointing us towards. I like using this graphic. It's quite dated now, but I still think it tells the picture of dementia globally, and the numbers that we really are all very familiar with, and highlighting the context of Africa in general. This is data from around 2015, but even by then the projections are that by 2050 we'll have 131 million people living with dementia globally, and around 68% of these will actually be in low middle income countries, and particularly Africa. And even as we speak, we know that most people living with dementia in Africa, sub-Saharan Africa, do not know they have dementia. They have not been formally diagnosed. So the numbers are already high and they are increasing. And it's important that we think about the next 20, 30, 40 years. What would that look like? Coming to Zambia, Zambia is really, it's a very young country with a relatively small population. There are only about 20 million people as we speak, based on the most recent census. It is a fast growing population. In the past, maybe 10 years, we have jumped from 13 million people to 19.6 million. I have to take in mind that Zambia, like most countries in sub-Saharan Africa, is and has been struggling to control HIV, which has really slowed population growth. But as we've gotten better control of HIV, we are starting to see a longer-lived population. And this is bringing us into a population where neurocognitive dysfunction and the effects of that are becoming more evident in a clinical setting. So just to give a point of reference, in 1990, the life expectancy at birth was only 49 years for the average Zambian. And this now stands at, excuse me, 59 for males and 65 for females as of 2023. When we look at the age distribution for Zambia, we still are a very young population, with only about 1.74% of the population being 65 years and above. But like the rest of Africa, which is an aging population, over the next 20, 30 years, we will start to see this dynamic change in that percentage of people living above 65 growing and growing. And that is going to give us people who are beginning to manifest clinically dementia. What do we know about the prevalence of dementia? The honest answer is very little. So the most recent estimates that we have, these are from the Global Burden of Disease, puts our prevalence around 3.6%. So this is around 26,000 people living with dementia in Zambia, and this is expected to increase to around just under 120,000 people by 2050, which is a 359% expected increase in the number of people living with dementia. So when we talk about why we know so little, is because really there's, for a long time, there was very little neuroscience research coming out of Zambia. So this is a slightly old paper that was done at the University Teaching Hospital that looked at the spectrum of neurologic diseases in a patient population coming through our outpatient and inpatient department at that time. And even back then, when we looked at a sample of 443 inpatients and 368 patients, expectedly the most numbers were coming from the HIV space, so neuroinfectious diseases, TB meningitis, things like that, were the leading cause of neurologic presentation in our clinic and outpatient. So dementia, when we go into the data, in the HIV positive population at that time, there was only about 6% of people who had screened positive. In the inpatient, and then in the outpatient, it was around 13%, but these are very small numbers. More recently, again, this is a hospital-based study that looked at and screened for delirium, mild cognitive impairment, and dementia in a hospital-based cohort. Again, even with very small numbers, unfortunately, we do find that there was quite a strong positivity in terms of screening, with from a sample of about 136 patients, you had 27% had screened for mild cognitive impairment, and 62% had dementia. So these are quite small populations, but they are pointing us to the fact that unlike what we have thought for a long time, especially in our space, that conditions like dementia were not there. It's just that we were not looking for them. So again, this is just the same paper I've just spoken about. Delirium, I think, was very interesting because we know that delirium can be a predictor of poor outcomes. So it could be one of the ways that we identify and look for patients coming in with dementia, because most of these patients will come to a hospital setting and not necessarily a primary care facility. So if we are sitting at 3.6% as a country, how do we compare with what is known about the rest of Africa? And again, there's very little, unfortunately, data coming from Africa, but that gives us such a wide range of prevalences from as low as 3.2 to as high as 20% of the population screening positive for dementia in some parts of Africa. And like I've mentioned, a lot of this is just because we don't have data. This is a review that looked at neuroscience data that was coming out of Africa from 1996 to 2017. And you can clearly see that there are regional differences in terms of how much research is coming out of Africa. So mostly Northern Africa, a lot from West Africa actually, and South Africa specifically. So it's important that we begin to answer the questions of, is there dementia in Zambia? How much dementia is there, by generating a lot more local research. I like to end on this 2 slides because where is what the little that we know, where is it pointing us? We know the risk factors. There are modifiable risk factors that increase the risk of people developing dementia. And across the whole sub-Saharan African region, we find that the non-communicable diseases are a predominant risk factor. So these are the 12 dementia risk factors. You have hypertension, diabetes, obesity. And then when you look at, for Zambia, the top 10 causes of morbidity, this is from Ministry of Health Statistics, you have HIV/AIDS remaining as number 1. So what are the HIV-associated neurocognitive dysfunctions that we are seeing? But you also begin to see that stroke, ischemic heart disease, and hypertensive heart disease and hypertension and its complications are consistently over the past 10, 15 years have been in the top 10 causes of morbidity and mortality. So it's important that we know that these risk factors are increasing, and then it can be expected that we will start to see the complications, and we're already seeing the complications of that in our Zambian population. And lastly, just to give an insight into what it's like to live with dementia in Zambia at the moment. Unfortunately, because of a general lack of knowledge about dementia in the general population, but also in the healthcare provider population, we do see a lot of delays in diagnosis and a lot of misdiagnoses of people living with dementia, which leads to a lot of social isolation. There's still a lot of stigma within our communities for people living with dementia. Support systems for people living with dementia are very poor and need a lot of work. And to some extent, they are still very real, very significant threats to life for people living with dementia, because people don't understand what it is, and there are misconceptions around what causes it and how one person develops dementia. So there are threats to safety and even to life for people living with dementia. Thank you very much.
Thank you so much, Dr. Mata. And we actually had the privilege of having the BBC Africa team come to Zambia and do a show for the Health Check series on what it's like to live with dementia in Zambia. So you can also Google that to get more of a flavor of that. But right now, I am pleased to introduce our second speaker, who's Dr. Faith Samushi. So Faith is one of our senior neurology residents who will be graduating in the next couple of months. And as part of her neurology residency, she undertook a research dissertation project looking at care needs amongst caregivers of patients with dementia. And so she's going to present her preliminary analysis of this work. So
thank you, Dr. Saylor, and hello, everyone. Thank you for this opportunity. I'll just go ahead and share my screen, and I hope you don't mind if I stop my video during my presentation. I thought I could show my face for a little bit and then get on with the presentation. I hope you can get me clearly.
Yes, it's excellent.
you can.
Great. Okay, so as was introduced, I'm Faith Simushi, a registrar of adult neurology. And this was my dissertation from my MMed for adult neurology that looked at the unmet care needs among adults with dementia and the informal caregivers in Lusaka. I don't have any disclosures to make, and this is just the outline of how my presentation will be. So I think Dr. Mata has already highlighted the epidemiology of dementia globally and also in sub-Saharan Africa. And like he mentioned, we know that more than 55 million people have dementia, and over half of these people are actually in the low and middle income countries. And as of 2023 March, WHO had actually stated that there's nearly 10 million new cases of dementia every year. And the expectation that this figure is going to actually increase in the coming 20, 30 years is quite alarming. But what is more alarming to us is that even the increase in the incidence of dementia cases is also going to be in sub-Saharan Africa because of the increase in the aging population over time. So with a growing number of people with dementia across the world, there's a routine practice to find or identify a source of regular caregiving. And this has become the usual practice now. But of note is that there's a difference in the way support systems for people with dementia are in the high-income countries and versus the low and middle-income countries such as Zambia. So in the high-income countries, there's often formal support systems, for people that have dementia and their caregivers. And this could also include adult care centers, residential programs, and institutions that have people that are trained and qualified to look after people with dementia. However, in settings such as ours, most of the caregivers for people with dementia are informal, and this responsibility is often taken up by family members, and these are the ones that serve as an interface between patients and the health services. Sorry, was there a question? Okay. So then WHO again recognizes that actually taking care of someone with dementia has a significant impact on the physical state, psychological, as well as social and economical impact. And this was part of the reason that justified the studies, especially for the fact that in Zambia, the challenges and needs of people that have dementia within the community and their caregivers was not previously identified or understood. And because of this, there was a limitation on the medical team's ability to address those needs. And this would also increase the risk of negative outcomes. But also, like Dr. Mata alluded to, the awareness and education regarding dementia is very limited in most developing countries. Most families still view dementia as being a part of normal aging, which is not the case. And as a result, very few seek help despite experiencing very significant strain as they look after their loved ones. So if the needs of people with dementia and their caregivers are recognized, then we'll be able to locally contextualize the interventions that are offered to these particular individuals. And this can also lead to a more comprehensive patient-centered care approach for the patients. So the objectives of the study mainly were to identify what the unmet care needs of community-based people with dementia were, as well as their caregivers, and also to establish what the baseline demographics of the patients and the caregivers were. And we also wanted to identify what the independent predictors of unmet needs among people with dementia and their informal caregivers. And we sought ethical approval from the necessary bodies that was required. It was a cross-sectional studies, and it involved community-based people with dementia, with each with an informal caregiver here in Lusaka. And these were recruited from the outpatient neurology clinic registry, but we did also have some referrals from the Alzheimer's Association. We had quite a number of people that were actually referred from the association. And the data was collected in the period of 3 months between January earlier start of this year up to March 2023, and we had a total of 33 people with dementia, and each had a caregiver. Each one had a caregiver. Our inclusion criteria was, as is highlighted, we had enrolled patients that were above the age of 18, and their diagnosis had to be according to the neurocognitive disorder, according to DSM-5. And these, of course, like I mentioned, were community based. So these participants underwent a one-time in-depth in-home assessment. And these assessments enabled us to collect information concerning their social demographic characteristics, some clinical characteristics, in particular the severity of the dementia, which was based on the mini mental state exam. And we also wanted to know what the performance in terms of activities of daily living was, and this was assessed using the Barthel scale. In terms of the caregivers, we used the Zarit caregiver burden scale to be able to know this the caregiver burden. And then in terms of assessing what the care needs were for both the patients and the caregivers, we used the John Hopkins Dementia Care Needs Assessment tool, which is a validated tool that has been developed by validated questionnaire that has previously used to identify and evaluate needs for people with dementia and their informal caregivers. It was developed for use by clinicians who are involved in evaluation and treatment of dementia, and also for professionals that were involved in delivering specifically community-based services for patients with dementia. And after having collected this information, a bivariate and multivariate regression analysis were conducted in order to identify what the correlates of unmet needs were in terms of demographics, socioeconomic, clinical, functional, and quality of life. So I mentioned we did have 33 participants. We had managed to reach out to 68 possible participants from both our registry at the clinic, as well as those that were referred to us from the association. And at first contact, 22 had declined participation and 4 declined consent for further in-house assessment. And we discovered that it's about 6 that we had reached out had relocated. And apologies, that is supposed to read 3 were excluded, not 13. And of the 3 is that 2 were not community-based. These were put in an old people's homes, and the people that were taking care of them. And then 1 did not meet the DSM criteria for the dementia diagnosis. So that's made us end up with 33 participants that were enrolled, and each of these had an informal caregiver. So in terms of, sorry about that, demographic characteristics. So the mean age for patients that had dementia was actually 79.6, and most of them were females. And of note is that most of the participants had actually attained an education, mostly being a primary education, but we had also a bit more that had a tertiary education. Most of the participants also did not have a personal income, and the duration of symptoms for those that we had enrolled was approximately 2 years. In terms of dementia type, most of the participants actually did not know the type of dementia that they had, or the caregivers did not know the type of dementia that they had. And then we have the proportion of others that had Alzheimer's, dementia with Lewy bodies, vascular dementia, as well as those that had mixed dementia. And then of note here is that these participants' diagnosis was actually based on a clinical evaluation. You may be aware that we currently don't have the capacity to do other tests like biomarkers and other particular imaging that can aid in getting a specific diagnosis for what type of dementia it is. So most of them was actually based on the clinical assessments. And then hypertension was noted to be the most common medical comorbidities, and we only had about 3 participants that were confirmed HIV positive. In terms of the dementia severity using the mini mental status, we had most of the participants having severe dementia, and we had about 21 with moderate, and the minority actually had mild dementia. And when we did the Barthel index scoring to see their functionality, most of the patients had a severe dependency. Based on the Johns Hopkins Dementia Care Needs Assessment, so the total possible number of patients needs was 72. So if you look at the original tool, the total number of needs is supposed to be 75. But when we tested the tool, we had to sort of remove 3 particular domains or needs rather that were not applicable to our setting, and this brought the total number of possible needs to 72. And from our statistics, the median number of reported patient needs was 59, and the proportion of unmet needs with, for the patients was actually 57. And of notice that the highest patients' needs were in the domains of diagnostic needs. So this is having a comprehensive or thorough workup for dementia and appropriate referrals as well that are supposed to be made for assessment and evaluation. But also there was a very high need in terms of general medical and healthcare, which is also inclusive of specialists, apart from general medical, as specialist care as well, was also a need. We already mentioned that there was quite a different comorbidities that most of our participants had. Apart from the hypertension, there were others as well that required specialist medical care. And then there was also a high need in terms of assistance with daily activities, meaningful activities, legal issues and advanced care planning, as well as resource referrals within the community. So when we did our bivariate relationships between the proportion, the various factors and the proportions of unmet needs, what was of note here is that there was a strong relationship between having attended tertiary education and having a high proportion of unmet needs. And if you notice, for those that had attended, rather having attended tertiary education actually has a negative beta coefficient, meaning the higher they had attained an education, the more or the proportion of unmet needs that one actually had. Then the other variable that was noted to actually be associated with a high proportion of unmet needs was having an unknown type of dementia, which had a p-value of 0.001, which was quite significant, because the statistical significance for this particular study or results was actually placed at a p-value of less than 0.1. And then in terms of the caregivers, of notice that the median age actually for the caregivers was at 58, and most of them were female as well. And the caregivers were, most of them had actually attained an education, especially gone as far as tertiary education. And most of the caregivers were also unemployed. Just to mention that some of these that were labeled to be unemployed had to stop work because they had to look after their loved ones. And similar to the patients that had dementia, hypertension was the most common comorbid condition. And in terms of the relationship between the patient and their caregiver rather, the most common relationship, I think, was that of, parent and child, parent versus child. In terms of how many hours the caregivers were putting in to look after this patient, it was about 100 hours per week. And when we carried out the Zarit burden for the caregivers, most of the caregivers were noted to have a moderate to severe burden. And this table just shows the various care needs that are associated with the caregivers, and just to highlight rather that the community resources and psychiatric care was the one that was seemingly the most need that was not met. We only had about 3 patients that needed psychiatric care, and none of those had actually gotten any either referral or were actually evaluated or managed. And then in terms of factors that were associated with unmet needs for the caregivers, when data analysis was done, what was noted is that having an unknown type of dementia for the patient is the one that was related with a higher proportion of unmet need for the caregivers, having a p-value over 0.01. And yeah. So in terms of a summary of the findings, so from what we had analyzed so far, most patients with dementia and their caregivers were noted to be actually female, and most of them had actually attained up to a tertiary education. And we also noted that hypertension was the most common comorbid condition in both the patients and as well as the caregivers. Most of the informal caregivers were not in any form of employment, and they spent about an average of 100 hours per week with their caregivers. And also that all the caregivers that participated in the study were family relations, with the most common relationship being that of a parent and a child. And I think the study done by Cabot in 2015 had indicated that actually most informal caregivers for older patients with dementia are usually adult family members or friends, and these usually provide care that is uncompensated. And then we also were able to note that as has been mentioned earlier, that having attained a tertiary education and having an unknown type of dementia was significantly associated with a higher proportion of unmet care needs for patients with dementia. So there's a limitation of studies that shows an association between the level of education and the prevalence of unmet dementia care needs. I think most studies that have to do with education or level of education or length of education have to do with the incidence of dementia and not so much with the prevalence of unmet needs. But there is a study that was done by Langer et al. In 2016, and it had reported that actually an increase in educational attainment was associated with some of the decline in the dementia prevalence. However, the full set of the social, behavioral, and medical factors contributing to the decline was still uncertain. Again, this is pointing more towards dementia prevalence and not to the care needs of the patients. And then also there was a demonstration that the low level of education among the caregivers was associated with an increased proportion of unmet needs for patients with dementia. So this one is a study that was done by Black et al. In 2031 that at least showed an association between the level of education with the unmet care needs for patients with dementia. However, this level of education was in the caregivers and not the patients themselves. So our study showed that having an unknown type of dementia was an independent predictor of unmet dementia needs for both the patients as well as their caregivers. And so symptoms of different types of dementia can be similar among different types of dementia. And some people can actually have more than one form of dementia, which can make an accurate diagnosis quite difficult. So not knowing the type of dementia that someone has then can pose a challenge in terms of how one should be looked after, because especially in the case where they might have a mixed form of dementia, it might pose a challenge in terms of meeting all the care needs that the patient can have. And in 2009, an article was published for a study that was done by Vanda Roos that demonstrated that actually the type and severity of dementia is it showed that was related to the number of reported needs that the patient and the caregivers had. We also talked about the different domains that the patient had experienced the highest proportion of unmet needs. I think we mentioned, we talked about the domain of meaningful activities. In our study, there was no participant that was able to identify any community adult care center or any center that had senior center activities. And we do know that such activities have been shown rather to help increase the patient's engagement and reducing behavioral symptoms and hence reducing caregiver burden. And also in terms of the domain of legal issues and advanced care planning, I think only about 2 participants had like a will in place, and most of them did not even know how to go about having a power of attorney or about going about having a will in place. So there was also very little preparation in terms of planning for the future. In terms of referrals for community resources, A few had an idea that there was a local Alzheimer's association that existed, but very few were members of it. And then also in terms of being part of a support group, there were very few caregivers that were aware that the association also had a support group and were actually members of that particular support group. Our study had a few limitations. So the participants that were enrolled for the study, they were not randomly selected, and they were recruited from one urban geographic area. So this sort of limits the ability to generalize our findings to the Zambian population of both the patients and their caregivers. And also, like I mentioned, this is a cross-sectional study, so it did not allow to establish like a causal relationship between the variables. So the participants' unmet needs were based on the Johns Hopkins Dementia Care Needs Assessment tool, and this one relies mostly on clinicians' judgments that consider participants' perspectives. And this may differ from findings that are derived from other tools that have been used to assess similar care needs. In conclusion, conclusion was that this study was able to identify that patients with dementia and their informal caregivers had unmet care needs, especially in the domain of meaningful activities, legal issues, and advanced care planning, as well as resource referral. And it also demonstrated that having a tertiary education and an unknown type of dementia was significantly associated with a higher proportion of unmet needs. So just some acknowledgements to the participants that agreed to be part of the study, to my mentor, Diana Sela, as well as the entire UTH and neurology team that were very, very instrumental in helping making sure that this study was actually a success. Thank you very much.
Thank you so much, Faith. I think this is such an important look at just the impact that having dementia has both on the patient as well as the caregivers. And you mentioned kind of the referral bias, that we had a pretty highly educated population here. And even with that, they had a significant proportions of unmet needs. And so certainly out in the rural areas with less educated patients and caregivers, I think the needs would be even higher. So really important work. So now I'm going to introduce our third speaker, and we're really going to kind of shift gears a bit. Dr. Mashina Chamba was one of the first graduates of our neurology training program. He's now a consultant or attending neurologist within our neurology training program and at the University Teaching Hospital. He has an interest in neuroinfectious diseases and neuroimmunology, and completed a neuroinfectious disease fellowship with Kieran Thacker at Columbia University. And he is going to talk to us about Alzheimer's disease and HIV-associated neurocognitive disorders. So you saw from Faith's study that HIV is not an uncommon risk factor for dementia in our population. And so we thought it would be interesting to see what we know about the commonalities between these two disorders. So Dr. Chamba, I'll turn it over to you.
Thank you very much, and good evening, good morning, good afternoon, everyone. So this topic is, as Diana mentioned, a very important topic in our setting. We have quite a high privilege of HIV in Zambia, as well as Faith and Dr. Mata have shown, we have quite some needs regarding dementia. For this talk, I have no disclosures to make, and I'll start off by discussing briefly the pathophysiological mechanisms of both Alzheimer's disease and HIV-associated neurocognitive dementia. Then we'll try and see what we know when we compare the two conditions regarding these mechanisms. I'll touch briefly on the clinical considerations, which are often a challenge for us. Then we'll look at some late data, and then I'll conclude. I will state that the literature review that made this presentation largely comes outside Africa. And that is one big challenge for a question that is very, very important to many countries within sub-Saharan Africa. So to start off, we'll discuss briefly the pathophysiological mechanisms for Alzheimer's disease. This is just a recap briefly, that it is a neurological disorder characterized by neuronal dysfunction and destruction with the accumulation of amyloid beta within the brain, and this in turn leads to tau pathology, particularly p-tau. It's also associated with formation of neurofibrillary tangles and plaques that the pathologies that are often observed within the brain. It is thought to have a genetic risk, particularly with individuals expressing the ApoE alleles. But we also do have sporadic cases occurring with non-familial types. And this may suggest environmental risk factors potentially contributing to the formation of Alzheimer's disease. Between the two, familial forms of Alzheimer's disease are thought to account for only about 5% of cases, that the environmental factors may play a much larger role than we think, despite this familial risk. Environmental factors include exposures to infectious agents, neuroinflammation, as well as chronic stress. And with chronic stress, it's important to note that data has shown that interrupting the anti-inflammatory mechanisms within the brain, particularly those regulated by glucocorticoids through the hypothalamo-pituitary adrenal axis, contribute to cellular damage that may accelerate the progression to Alzheimer's disease. When we shift to looking at HAND, we know that the HIV virus is very neurotropic, and there are studies that have shown evidence of neuroinvasion as early as 2 weeks into the primary infection. So it is affinity for the brain. The virus does this by entering the central nervous system through a mechanism often referred to as a Trojan horse type of mechanism, utilizing infected monocytes that traverse the blood-brain barrier and carry the virus into the brain. Once in the brain, there's viral replication, and this leads to compartmentalization within the brain. The brain is often referred to as a reservoir for HIV. Following replication, there's release of viral proteins, and these viral proteins lead to cellular destruction and inflammation of both glial cells as well as neurons themselves. And this pathway is largely responsible for what we refer to as HIV-associated neurocognitive disorder. This is a schematic that illustrates this mechanism. In the numbering that you may see on this is numbered 1 to 6. You see that in the first, that's the illustration of the Trojan horse mechanism with the macrophages carrying the virus. Infected macrophages carry the virus into the parenchyma of the brain, and this activates astrocytes. Astrocytes then cause release of inflammatory proteins, and this further destroys oligodendrocytes and other cells such as the neurons within the brain, and eventually you get pathology that is referred to as HAND. We often classify HAND into 3 different categories based on severity, and these include, in order of severity, asymptomatic neurocognitive impairment, mild cognitive impairment, and HIV-associated dementia. That severe form was often seen commonly prior to the onset or the advent of combination antiretroviral therapy. And it was largely thought that after introduction of antiretroviral therapy, and altogether, but particularly HAD, which is the most severe form, was largely non-occurring. However, recent data is showing more of a resurgence of HAND as populations of people living with HIV age. And it is observed that the manifestation of HAND now tends to lie mostly within the non-severe forms such as ANI and MCI. So the question of differentiating Alzheimer's versus HAND remains a very important question as we see people living with HIV living longer. And it's become very important to try and understand and differentiate them both pathologically, clinically, and perhaps through imaging. It's also worth noting that in some patients, both conditions may occur simultaneously, and it's postulated that they may have a similar pathway leading to both conditions, although some studies show potentially different pathways, which we'll discuss later. One very important pathway that we could consider is that the viral proteins implicated in hand also stimulate excitotoxicity and dysregulation of the HAP axis through the glucocorticoid receptors, and this may potentiate the onset of Alzheimer's. This is illustrated in this schematic from literature, and you see that the 7 different pathological pathways that lead to synaptic destruction and cognitive decline are both stimulated by HIV viral proteins as well as glucocorticoid receptor impairment. And this common pathway is one that is postulated to perhaps leading to hand, but perhaps also to Alzheimer's. And a lot of work is ongoing in understanding how these 2 pathways may lead to the same, the 2 conditions. One interesting pathway, or one interesting piece of data that may show evidence of similarities in pathology is when we consider the CSF biomarkers that we observe in patients with hand and compare to those we see in patients with Alzheimer's. In one of the earlier studies looking at this was a study out of the US in 2009, which looked at about 50 patients with hand and 50 patients with HIV, 50 patients with a dementia of Alzheimer's type, and 50 controls. And it's observed that looking at CSF amyloid beta 42 levels, the levels amongst the patients with hand were significantly lower than the control group and significantly lower than patients who had HIV but didn't have neurocognitive decline. And this low level of amyloid beta 42 may suggest the deposition out of the CSF into the brain parenchyma as observed similarly in Alzheimer's dementia. But what we do know about Alzheimer's dementia is that despite the low CSF amyloid beta 42 levels, we get a high occurrence of tau protein in the CSF. So when this study looked at the tau levels amongst the 4 groups, of interest was that the levels within the patients that had hand were much lower than the patients who had Alzheimer's. And this may suggest a distinction between the 2 entities, in that perhaps amyloid levels may be low in both conditions, but unlike Alzheimer's, hand does not manifest with a concurrent high level of tau. That could potentially be one way of differentiating the 2 conditions. When you consider the clinical manifestations, it is very difficult to distinguish between Alzheimer's and hand. And we do have screening tools for dementia within patients with HIV that have a sensitivity and specificity of about 60 to 70% respectively. But they are not very good and reliable for distinguishing hand from Alzheimer's. So a few things to consider may be that it's possible to have both conditions in one patient, so that's always important to note, but that the progress of Alzheimer's tend to be more rapid despite ART, whereas in the presence of ART, hands may stagnate in a patient who has HIV. It's also worth considering the potential neurological effects of the antiretroviral therapies themselves that may complicate the clinical picture. So still a very complicated subject and a huge area of interest. One way that has recently come into prominence in literature is trying to differentiate the 2 conditions through brain imaging. And one modality is the positronic emission topography, and this is a PET scan that looks for amyloid deposits, which we all know is quite useful in diagnosing Alzheimer's. Few studies have been done looking at this modality, and the data is largely inconsistent. And it's very hard to conclude if we actually know a good way of differentiating the two conditions based on PET. One theory is that the amyloid plaques formed in hand are intraneural, while those in Alzheimer's are extracellular. And the stain used in PET scans, known as the Pittsburgh compound B or PIB, tends to bind more readily with extracellular plaques, making it more difficult to visualize in hand because PIB only binds to extracellular plaques, unlike those found in hand. So we may be missing positive scans because of the stain utilized in many of the studies done so far. I'll give one quick example of a study that looked at this in 2020, and this was done in Australia, and they looked at 8 men living with HIV that had a diagnosis of hand, and they compared their PET results to a large national image bank of patients that had cognitive normal conditions, as well as PET scans of patients who had Alzheimer's and other forms of dementia. This illustrates the differences noted, and I hope you see this very solid black line right around the center of all the lines on this graph. That represents the patients who had hand. And you see that this compared to those that are red and that are yellow were significantly lower results of the uptake. And this suggests that there's a PET scan of a patient with hand doesn't show as much deposit as we see in Alzheimer's and other forms of cognitive impairment. They did note that 1 out of the 8 participants, and that is the patient who shows the line that is green, that's a deep green at the very top, had an unusually, out of the group, a very high level of deposit seen on the PET scan. And this was more or less an outlier in the group. And so this is a good example of the inconsistency in the data. Although the group analysis showed much lower deposit of amyloid, we had 1 out of the 8 showing a higher deposit than the rest of the groups. And this was difficult to explain. When you look at the actual images, you note that the 8 scans showed here, the scan in the top right corner, second from the right at the very top, is that participant who had a high deposit. And you can see how much of the brain lights up on this PET scan. And so it was postulated that this was a participant who had tested positive for the ApoE gene. And the conclusion by the authors was that they may have had both hand as well as Alzheimer's in the same patient. So still yet to find a good way of distinguishing between the two conditions based on a PET scan. More recently, there's been some work using magnetoencephalography, which is a imaging modality that looks at cognitive responses and the brain waves when a patient has a task, and it tells a lot about one's ability to complete a task and their cognitive impairment. When both groups of patients with Alzheimer's and hand were compared to controls that were cognitively normal, there was a significantly higher aberration in their ability to complete a task compared to the control. When comparing Alzheimer's group to hand, it was found that in the Alzheimer's group, there was more interference within the frontoparietal, occipital, and temporal cortices, perhaps suggesting a difference in predilection for regions of the brain between the two conditions. But these results still may suggest an overlapping pattern of neurophysiology. In conclusion, the relationship, if at all any, between hand and Alzheimer's is still very unclear and remains an area of great importance globally, especially that we're seeing longer lifespans among people living with HIV across the world due to ART. And there's a lot of work going on in this area. And this is a great opportunity for more work within our region and collaborative efforts to try and understand this question a lot better. So thank you for that. And I'll stop here. Thank you.
Thank you so much, Machina. And I know we're running very short on time, so I will just quickly wind up here with a brief kind of overview of where we're hoping to go with dementia research in Zambia. So I think one of the things that we're really excited about is the opportunity to participate in community-based participatory research. And this is particularly through Dr. Mata and Dr. Samushi's involvement in ADIS, which is the Alzheimer's disease and related dementias in Zambia group. It's a community-based organization for patients with dementia and their families. They hold multiple community awareness events each year. And then recently, Dr. Mata and Samushi also received a grant to hold a dementia symposium for both patients, caregivers, and healthcare workers. And so they've really done a lot of work to raise community awareness and also awareness within the medical profession in Zambia as well. And I think that these relationships and the strong connections with the community will really allow us opportunities to think about designing community level interventions to raise awareness or change healthcare seeking behavior for dementia. I think the opportunity to do trials of group-based interventions for patients and their caregivers, and then also to obtain community input on proposed clinical trials or other research studies so that we can make sure we're really responsive to what the community of people with dementia in Zambia want. Dr. Jeremy Tanner, who I think is on the call as well, is faculty at the University of Texas, San Antonio in cognitive neurology, and he's been doing a lot of work in Uganda, looking at dementia, and is expanding the work into Zambia as well. And so really thinking about what cognitive assessments work best and maintain their relevance in a non-English speaking, low literacy, predominantly rural population. And also, not only are we not sure about how well cognitive assessments work, but we also don't have neuropsychologists. So how can we still have feasible cognitive assessments? Can we use a tablet-based assessment with sort of automatic scoring that could help us? Dr. Melissa Alafros, who I think also is on the call from the University of Michigan, is currently working with Dr. Tanner as well as Dr. Mata and Samushi on the Zambian cohort of healthy aging and dementia study, the ZCHAD study, which is essentially trying to generate some population-based data regarding the prevalence of Alzheimer's disease and risk factors. They're doing this through a two-stage study design using community health workers to go door to door in randomly selected sections of two high-density neighborhoods. They'll be doing household questions to screen for cognitive impairment and risk factors. And those that screen positive, as well as sex and age match controls, are invited to come into the clinic for formal neurocognitive testing, as well as a neurologic examination. And so the goal here is really to establish preliminary evidence on estimates for dementia and risk factors and identify a screening tool that can be used. And so this study is ongoing. And Dr. Samushi was recently awarded a pilot grant from the American Neurological Association to really look at reversible causes of dementia in this study as well. And so I think just in summary, our approach has really been to start small and build big in all things neurology in Zambia. So you heard about Dr. Samushi's work that actually was completely unfunded and was done just through sheer determination. And now we have the ZCHAD going on, and that has even been further extended by the ANA pilot grant. I think this also shows the importance of partnering with patient support groups and advocacy groups to open opportunities for more community-based participatory research. And then collaborations are essential. So most of the work that we're doing now could not be done without Dr. Alafros and Tanner. And so we're really excited for these partnerships that continue to support building capacity within our Zambia neurology team as well. So Kyle, I don't know if we still have time for questions, but I will turn it back over to you.
Yeah, absolutely. I mean, if folks are still able to stick with us, it would be fantastic. I think, thank you so much, all four of you, for these fantastic presentations and sharing all of the great work that's going on over there. Let's go ahead and open it up to questions. I can call on people, you can stick them in the chat. We can go from there. Well, I guess I'll go ahead and get it started while people sort of get their thoughts together. I did wonder in the hand space. Obviously, it's going to depend on HIV infection rates in males versus females. But is there a sex bias in terms of hand, in terms of it affecting women either more frequently or more severely, or men? And obviously, obviously it needs to sort of account for underlying HIV infection prevalence. So I didn't know if we know about that, or if that's something that's not been looked at sort of fully.
I think that's a great question. And I think the answer is both yes and we don't know. So, there are some data that suggests that women are more frequently affected by hand. But there's also a lot of confounders there. So one of the main protectors against developing hand is cognitive reserve, which is highly correlated with education. And especially in Western cohorts, the males tend to be more highly educated, and that's certainly true in sub-Saharan Africa as well. We don't have good data from sub-Saharan Africa on sex differences. We also have the confounder in sub-Saharan Africa that many men are often linked to care later, and so often have more severe disease. And there's a lot of data to suggest that the worst level of HIV control that you have at any point is correlated with cognitive impairment in the future. And so with men coming to care later with more advanced disease, that puts them at higher risk of hand. And so I'm not sure that there's necessarily an inherent sex difference, but sex is associated with other factors that are linked to hand risk. And again, most of this data is from Western populations. And so we don't know as much in African populations.
All right, thank you. And then I guess I also wondered for Faith. I recall that in your set of patients and persons living with dementia and their caregivers, you said it had been about 2 years that they reported that they had been experiencing these symptoms prior to either getting formal diagnosis or coming to clinic. Is that right? And if so, how does that compare with, other countries, with, the US, with, rural communities here and other people's work?
Thank you for the question. So the 2 years was, I think the median, the mean duration of symptoms that patient had, and I think it varied from about 18 months to maybe about 5 years. In terms of how it compares in other countries, I really can't remember off the top of my head, but I think from the studies, that is, from my particular study, that's what we noted. I think the average duration of symptoms for most of the patients was around 48 months.
And did that correlate at all, or did you look to see in your data if that correlated with higher self-reported needs and unmet needs? Yeah.
That one did not.
Did not. Okay.
Thank you.
And I guess sort of, logistically, how much of that is a knowledge about dementia issue, and how much of that is a, transportation, logistics, access issue? And they're probably complementary in that way.
Sorry, could you just repeat your question?
Yeah, if one wanted to sort of accelerate that timeline so that individuals were, spending less time experiencing symptoms and not receiving a diagnosis and potentially care, would you be thinking more about intervening in terms of education about the symptoms so that individuals would be quicker to, seek a diagnosis? Or do you think it's, that families knew something was wrong, but that logistically it was difficult to to travel to the medical facility that they would need to go to get the diagnosis?
Yeah, I would think it's a bit of both. Education, not knowing whether there's something wrong with a patient that might need medical attention. And I think one of the reasons I think Dr. Mata had alluded to is sort of the stigma that's associated with patients that have dementia, especially because of the symptoms that they present with. So most of the times you find people seeking medical attention for their loved ones, and they can be kept at home until they probably progress to a point where they feel they're unable to look after them on their own. So it is an issue of education, but also in terms of access to medical care is also another challenge as well. Not just in terms of transportations, but also I think the availability of neurologists across Zambia. I think it's been mentioned that the program is relatively new, we would say, but even the ones that have already qualified as neurologists, I think the bulk of them are actually in Lusaka and at UTH. Most of them are actually based at UTH. And so I think it's a bit of both, the education and also the access to medical care as well.
If I could just add a little bit onto that, when you talk about education, I think it's not just for patients and caregivers, but also health workers as well. Mm-hmm. Because we have found, and the Z-chart will look a little bit about this, that patients may have had previous contact with some kind of health service provider who did not pick up that this could be dementia, and that is also delaying a formal assessment. So the education and just being able to look out for dementia needs to also be spread to health workers, and just having a higher index of suspicion that this could potentially be dementia.
Jackie just pointed out, Stephen, did you have your hand up? Did you want to ask something, or has it been addressed?
Thank you very much.
Yes.
I just wanted to say three things. First of all, thank you for the great presentations. I was very fascinated about the issue of a cohort or dementia in Zambia. You're really doing quite a lot of work. I'm from Makerere University, Kampala, Uganda. I've visited the University of Zambia once. And I've just shared in the chat some article about cognitive stimulation therapy, the scoping review, and it's published, but it's pending review comments. Probably could have a look at it. And one of the things I'm interested in is how to pilot cognitive stimulation therapy as an intervention for people with dementia in Uganda. So if there are any ideas, people who have dealt with that, I would be very happy to have a conversation. Lastly, I have a grant from Alzheimer's Association, and I'll be trying to estimate the prevalence of dementia among older persons in Eastern Uganda. I'm new to the field. I'm a demographer myself and gerontologist. But I'm working with, I've had interactions with Jeremy. I saw Jeremy, and Jeremy has talked about Diana, and Mark who's working in Mbarara. So I'm just saying thank you for organizing this webinar. It's late, around midnight in Uganda, 11 in Paris, where I am. But I had to stay to listen to this. You're really doing a good job. Keep going, and let us know when you're calling for more of this kind. We can have conversations to share our ideas and see how we build this research agenda on the African continent. Thank you very much.
Thank you. And I think it's a great point, is, even here, we're trying to get our geriatrics groups, right, to integrate better with our neurology groups, and it's not always a completely seamless thing. We have Jan on, who's the division chief for geriatrics at UNC, and co-leads the rec with me, and I think she can attest that that's not straightforward, but is certainly incredibly valuable, and to see that, you know, you and Stephen might be able to make that happen in Zambia would be fantastic, because, you know, we're trying to do the same things.
Absolutely. Just applause to you all. You're doing such phenomenal work, and really making those connections with our colleagues in other areas. That's really, I think, what really sometimes spurs our inquiries and our accomplishments and research, because we're able to look at multiple viewpoints. And of course, for the purposes of this forum is the crosstalk, and to enable people from multiple backgrounds and multiple disciplines to be able to converse together and learn from each other. So thank you all for spectacular presentations. Really appreciate it.
Thank you so much. I think we'll go ahead and end it there, because as mentioned, it is late for you, and we appreciate your time so much, and your patience with us. And thank you for joining us. And for any of those who registered for this, you know, we have these forums every month, and they're not always on global health things, but you're always welcome to join. They are open, and we talk about some interesting things. So we hope to see you all again soon.
Thank you very much.